Hello everyone, this is Dr. Aisha. Now let's go and dive into surgery choti coping. So let's go fast and clear. We have chromosome 17 and chromosome 13. Let's start with that. Chromosome 17 is associated with BRCA1, NF1 and P53. Chromosome 13 is associated with 3, right? So ATP7B, right? RB, again I can write 32, and BRCA2. So this is what is associated with chromosome 13. With chromosome 17, I have NF1, BRCA1 and P53. Okay. Now let's go and see what's happening in the varicose vein. You have a CEAP classification of the varicose vein, which is based on clinical, etiological, anatomical, and pathophysiological. In that, we are dividing the varicose vein types into C1 to C6. C1 is telangiectasias reticular vein. C2 is varicose vein. We also have C2R, which is recurrent varicose vein. 3 is E, always 3 is E, so it is edema. C4 is pigmentation. You have ABC. A is pigmentation of eczema. B is lipodermatosclerosis or atrophic blanchie, and C is corona phlebitica. So A is pigmentation or eczema, 2 is lipodermatosclerosis, and C is corona phlebitica. 5 is always good, so 5 is healed. 6 is active venous ulcer. 6R is recurrent active venous ulcer. Lymphedema is divided into 1, 2, 3. 1 is pitting edema, 2 is non-pitting edema, which is also known as a stemmer sign, and we have 3, which is associated with irreversible changes. It has papillae and fibrosis. So in such cases, this grading is known as the Brunner's grading. So lymphedema, you have the Brunner's grading. It has divided into 1, 2, 3. 1 is pitting, 2 is non-pitting, which is known as a stemmer sign. 3 is irreversible skin changes. Okay. And for this, we do a surgery which is known as the Charles limb reduction surgery. Perineural invasion is seen in 3 cancers. So perineural invasion, remember PAP. Perineural invasion, PAP. P, prostate. A, adenocystic salivary tumor. P, pancreatic. So perineural invasion, PAP. Okay, prostate, adenocystic cancer, and perineural invasion and pancreatic tumor. Prostate, adenocystic and pancreatic. PAP. Okay, perineural invasion, PAP. Prostate, adenocystic and pancreatic. TERP. Now let's just see what is happening in TERP. So TERP is the treatment for prostate cancer, BPH. Alright. So for this, we are using a monopolar photry diathermy. In that, we are using NDYAG or MOYAG, for which MOYAG is the best. And after that, post-op irrigation, you are doing it within 18 FR, that is the red color 3-way catheter, and you're using normal saline. But while doing the surgery, you use a cystoscope and you cut through with a monopolar diathermy. And to wash it during the surgery, we use isotonic glycine. This is what I want you to remember. Isotonic glycine, 0.5%. 0.5% is preferred to distilled water. So you can use distilled water if you don't have isotonic glycine, 0.5%, but we prefer isotonic glycine. But never will we use NS, because NS is a good conductor of electricity, and therefore we will have poor cutting and coagulation. And there is also one more point that is known as the Verimuth point, Verimontanum. This Verimontanum will serve as the distal limit of TERP. So beyond this point, if you do TERP, you are going to damage the external sphincter. So that's all about it. And now we'll go to stomach. So stomach, first you need to know about the H. pylori. H. pylori is grown in a medium which is known as a sciromedium. It is a gram-positive cocobacillus. It has Lophotrochus. So what is Lophotrochus? This is Lophotrochus flagellae. Okay, and then the stain that we use, it could be Brown stain, it could be Warthin-Starry silver stain, and it can be Giemsa stain. So we have Kage-toxin and Wage-toxin. Kage-toxin is associated with cancer, and Wage-toxin is associated with peptic ulcer disease. So when you have a peptic ulcer disease, what is the treatment which you give? That is LAG-2, lansoprazole, amoxicillin, and clarithromycin. Lansoprazole, amoxicillin, and clarithromycin for 2 weeks, or you can go with a quadruple regimen, which is lansoprazole, azithromycin, amoxicillin, clarithromycin. Along with that, I'm giving bismuth also. This is known as a quadruple regimen. How do I test for it? I can see C13-14 breath test, but this was an old test. We don't do it anymore. So what do? Now we look for the stool H. pylori antigen, okay? And rapid test, we have the rapid urease test. This is actually an invasive test, all right? We have to use an endoscopy, get the specimen, and then you put it in the strip, and if it turns pink, it means that there is H. pylori, yellow to pink, which means there is H. pylori in it. But we have a non-invasive test, which is ELISA. So invasive test is rapid urease test. Alright, where we use endoscopy. Non-invasive test is ELISA. Now we have a duodenal ulcer and gastric ulcer. Duodenal ulcer, there is pain relief when the patient eats. Pain is decreased on eating, so the patient will eat a lot. So duodenal ulcer, if you have, you will be double your size. All right, that's how I remember. Duodenal ulcer, if you have, you will be double your size. If you have gastric ulcer is due to the mucosal barrier. So when you eat, there will be pain. All right, when you eat, there is going to be pain. So what you will do? You will not eat. So gastric ulcer, you will be very lean. Duodenal ulcer, you will be double your size. All right. And there are gastric ulcers. There is a modified Johnson classification of gastric ulcer. Modified Johnson classification of gastric ulcer, in which you have type 1, 2, 3 and 4. 1, I hope you remember. It is the most common one. It is seen in the incisura. It is seen in the incisural antrum. 2 is dual ulcer. Okay, one in duodenum and the other one in the pylorus. All right. Now 3 is pre-pyloric ulcer. So 3 is pre-pyloric ulcer, which is seen mostly because of increased gastric ulcer acid secretion. 4 is in the first. So it is the proximal ulcer. 4 is the first one. So it is a proximal ulcer. So 4 is this is proximal ulcer. 5 is NSAID induced ulcer due to the loss of mucosal barrier. This is the Johnson criteria for gastric ulcer. Now, how do you treat it? You do a high selective vagotomy, which has a high recurrence. You can either or else go for a truncal vagotomy with gastrojejunectomy, truncal vagotomy with pyloroplasty, or truncal vagotomy with antrectomy. Antrectomy has very less recurrence of less than 1%. Alright. Now, when you have a gastric ulcer, how do you treat it? So, when you're having type 1, we already know what is 1. 1 is in the antrum. Is in the antral, incisural antrum. So for 1, we do wedge resection, just remove that part. For 2 and 3, 2 is dual, 3 is pre-pyloric. For that, you do a truncal vagotomy with distal gastrectomy followed by Billroth 2. I'll tell you what is Billroth 2 and Billroth 1. Now we have gastric ulcer type 4. So 4 is the one that is seen in the proximal stomach. Okay, this is type 4. The treatment for that, there are 1, 2, 3 types of treatment for it. The first one is the pouched procedure. So what I do is I just remove it as a pouch. This is pouch procedure. 2 is Madeliner's procedure. So why do we call it Madeliner's? Because the ulcer is here, I am removing this part. So this is Madeliner's procedure. Now what is 3? 3 is Senday's procedure. The ulcer is here, I am removing whole of this. And this is all followed by Billroth 2. Okay. Now the perforated duodenal ulcer, the close differential diagnosis is pancreatitis. If it is posterior, you know there is a risk of bleed. If it is anterior, there is a risk of perforation. Alright. So and then if there is a perforation, you look at the size of the perforation. If it is less than 1 centimeter, you can do a direct closure. It is 1 to 3 centimeter. That's less than 3 centimeter, less than or equal to 3 centimeter. You can use a Graham's patch with amendum, less than 3 centimeter, less than 1 centimeter, direct closure. Less than 3, less than or equal to 3 centimeter, use a Graham's patch with amendum. If it is more than 3 centimeter, I will do a jejunal serosal patch. Alright. So that is what you do here. And then I told you if there is a posterior perforation, posterior ulcer, it can lead to bleed. Okay. So when there is bleed, what do? First, I'll do a rise tube compression, IV fluids, and I'll give pantoprazole. If the patient is a known case of tertiary bleeding, I would give octreotide. If there is a known case of trauma, I would give tranexamic acid. Very good. And then the next thing that I would do is endoscopy. I'll just first stabilize the patient, then I'll take the BEM for endoscopy. From the endoscopy, I have what is known as the Forest classification. So this is the Forest classification in endoscopy that we have. Okay, so in that we have Forest, you have 1, 2, 3. One has spotting, oozing. 2 can be A, B, C. A is non-bleeding visible vessel, B is adherent clot, C is flat spot in ulcer crater, and 3 is clean base ulcer. Alright, now after that, I can do the treatment. So how do I do the treatment? If it is having any active bleed, that if it is 1, or if it is non-bleeding visible vessel, in these cases I will do endoscopic clip or coagulate, and then I will give an adrenaline injection. Okay, this is what I would do. But for these 3 cases, if it is a clot, flat spot in ulcer crater, or a healed ulcer, that is from 2B, I will just discharge the patient, nothing else is necessary. Now the third step is, if there is 2 times failed endoscopy, if the patient is having a rare blood group, if the patient is hemodynamically unstable, if more than 6 units of blood has been transfused, the patient is still not stable, or if more than 3 units of blood has been transfused in a single day, I would proceed with surgery. And then in surgery, what do? I'll do a 3-point ligation, that is gastroduodenal artery and its blood branches. I'll do a 3-point ligation. And then there is a Rock-Hall and Blatchford score that is used to score the UGI bleeding. So this is Rock-Hall score. So in Rock-Hall score, you use SC. One more E is there, okay? SC, age, shock, comorbidities or illness, endoscopic findings, and that is endoscopic diagnosis and endoscopic stigma of recent hemorrhages. That is, if it looks as if there has been a recent hemorrhage or something like that. Next you have is Blatchford score, which use only clinical and lab values but not endoscopic. Alright, so that's all. Next we'll look at a cancer stomach. There are, one thing is anemia. Pernicious anemia and blood group A is predisposed to carcinoma stomach. Pernicious anemia, there is going to be cancer on the proximal stomach, okay? Antrum is not affected, only the proximal stomach is affected. Now similarly, H. pylori, it will affect the antrum. Proximal stomach is spared. So H. pylori, distal stomach is affected. Pernicious, proximal is affected. Pernicious, proximal. Irish nodule is left axilla. Verrucosus, left supraclavicular. Okay, Blummer-Sheffner's pouch of Douglas. Now there are 2 cases where you cannot operate a cancer stomach. One is pancreatic infiltration, the other one is liver mets. Liver mets and pancreatic infiltration do not operate, okay? Now you also have 2 other classifications. One is Japanese and the other is Borman. Japanese, as you note, in Japanese classification there is 1, 2, 3. In Borman it is 1, 2, 3, 4. In Japanese, 1 is protruded, 3 is excavated, 2 is ABC, superficial, flat and depressed. Borman is 1, 2, 3, 4, polypoidal, ulcerating, fungating, linitis plastica. So that's how we do it. 2 cases where you cannot operate is pancreatic infiltration and liver mets. Okay, 2 types of cancer stomach. One is diffuse and intestinal. Diffuse is associated with E-cadherin and P53 mutation. Usually affects young girls. Okay, diffuse young girls. Okay, because you can always think young girls are very diffuse. Now intestinal classification is actually well differentiated cancer. It's associated with beta catenin, loss of heterozygosity of APC, BCL2 mutation, loss of heterozygosity of APC, BCL2 and beta catenin mutation. What is the treatment? That is, you can do a subtotal or total gastrectomy. The margin that you leave is 5 cm, 16 nodes removed, plus D2 lymphadenectomy. D2 lymphadenectomy is from 1 to 12A. 12 is hepatoduodenal nodes. Now there are 3 types of reconstructions that you can do: Billroth 2, Roux-en-Y, and Roux-en-Y esophagojejunnal. Now we'll just see the difference between Billroth 1. No, before that, if you cannot operate, you can go with palliative treatment, then ECF regimen and float regimen. These are the two chemotherapy regimen. Epirubicin, cisplatin and 5-fluorouracil. This is known as the Cunningham regimen. Okay, Cunningham regimen. Epirubicin, cisplatin, 5-fluorouracil. Float regimen is 5-fluorouracil, leucovorin, oxplatin and taxanes. This is the new regimen. Now there are two types of cancers that we can see in the stomach. One is non-Hodgkin's lymphoma and gastrointestinal stromal tumor. Non-Hodgkin's lymphoma, you can give R-CHOP regimen, and it has Lugano staging. R-CHOP is rituximab, cyclophosphamide, hydroxyadriamycin, and coven and prednisolone. Alright. Now we don't do surgery for non-Hodgkin's lymphoma unless there is some, severe bleeding, perforation, obstruction, in intractable pain, or it does not respond to chemotherapy. Unless otherwise, these factors, you don't operate a non-Hodgkin's lymphoma. It just goes away with your R-CHOP only. Next, you're having GIST. GIST is associated with c-KIT. c-KIT is CD117 in 90% of the cases. In 90% of the cases, c-KIT is there. CD34 is seen in 80% of cases. PTGFR is seen in 95% of the cases. Anectamin is seen in 95% of the cases. Now, c-KIT, CD34, anectamin, PDGFRA, and DOG1, these are the markers. If the tumor markers are absent and it's a GIST, then it is known as a wild GIST. Wild GIST is something which is SDH deficient. So, GIST is actually originating from the cells of Cajal, which is the pacemaker cells, which is present in the muscular layer of the GIT. Lymphoma is coming from the lymphatic tissues in the gut wall, which is usually submucosal or subserosal. Now, we need to call something a primary GI lymphoma. There is a criteria which is known as the Dawson's criteria, which says no other place should be involved. In a very simple way. How do we say that? Confined to one organ only. No liver, no spleen, no bone marrow, no generalized lymphadenopathy. Confined to one organ only. In such case, you can call it, primary GI lymphoma, which is undergoing Dawson's criteria. So, the diagnosis for both, how do you diagnose both, that is non-Hodgkin's lymphoma and GIST, the diagnosis for both is to, endoscopy is difficult to diagnose. So the investigation of choice for both is endoscopy guided, endoscopic ultrasound guided biopsy, or guided or CT guided biopsy. Mainly biopsy is what we do. Alright. Now the treatment of choice for GIST, that I didn't say, is resection. Just remove it. Okay, you just remove it. And you also have something called as a modified Jones-Hu criteria for it. Lugano staging is something that we had for non-Hodgkin's lymphoma. If it is non-gastric, if there is tumor rupture, the size is more than 5 cm of the mitotic index is more than 5/50. In such cases, there is bad prognosis. In such cases, you give the patient imatinib. Okay, that is tyrosine kinase inhibitor. So modified Johnson criteria, tyrosine kinase inhibitor, that is imatinib. And the cases for bad prognosis. Now you have something called the Carney's triad, which is just paraganglioma and chordroma. Next, you have the Alvarado's classification for the acute pancreatitis, which is Mantarin, where T is 2, leukocytosis of 2, T2, L2. Alright. Next, monitor the regimen while you are giving the patient a TPN. You have to monitor weight, fluid balance, CBC, urea electrolytes, urine output, and temperature every day. I know you won't be able to recall all of them, so let's just highlight the important ones. Alright. Weight should be checked every day. CBC electrolytes should be checked every day. Urine output, temperature. Now, weekly calcium, magnesium, zinc, phosphate, osmolality, LFT, RFT, albumin, thiamine, acid base, triglycerides. 2 weekly, this is something that I want you to remember. 2 weekly only you will check B12 and folic acid. Alright, 2 weekly only we'll check B12 and folic acid. Only 2 weekly is checked. Then all the iron, lactate, and trace elements. So that's all about stomach.